Dr. Talbot, perhaps you could let Dr. Chin make sure that his own speakers are on.
Yep, I'm texting him now.
Great. All right, so we're going to get started in just a minute. We do have a number of individuals on the call today here to help answer your questions. I know it's been a couple of weeks since we've had the opportunity to meet together, and we're excited about this chance for us to come together, hear how your school year is going in terms of starting, and for us to be able to share any updates and some key reminders based on the types of questions that we have coming into us here at the health department. So I think I will go ahead and turn it over to Dr. Chan if you're ready to begin. And just a reminder that you can ask us questions today through the Q&A feature in Zoom. Please don't ask your questions in the chat. We'll just reserve that for any technical issues or sharing of links, web links, and that kind of thing. Please ask your question in the question and answer feature in Zoom.
Okay, sounds like Ben is on now. Ben, sound check again. Oh, Ben, we don't hear you.
Yes, I can hear you now. Hopefully you can hear me.
We can, welcome.
Thank you, and apologies for the delay here, and apologies to everybody for the technical issues. I'm in my mobile office, so hopefully the connection holds okay. And Dr. Daly, are we okay to get started?
Yes, please proceed.
Great. Let me first actually start off with just a few comments. We've been hearing the struggles that you all have been having on the front lines, and so I want to first start off by thanking you all for the work that you're doing to try and protect kids, keep childcare and schools in session. And really just thank you for sticking with us, voicing your concerns, voicing your questions, and we are committed to try and address those questions and concerns. And I know that there have been aspects of some of the resources and guidance that we've put out over the last months that have not maybe been as clear as they should have been. And so one of the things we want to do on today's call is really to try and rectify that and try and see if we can address the many questions and concerns that we've been hearing about, and try and clarify what it is that New Hampshire Public Health recommends for schools and childcare agencies as you're starting the new school year. I also just want to call out very briefly the team that we have helping to support all of you on the front lines, and very much want to recognize Cheryl Nielsen, who I believe is on this call, for all the work that she's put in over the last several weeks, taking the questions, trying to put out accurate and reliable and consistent information. So just want to give a big shout out and thank you to Cheryl, because this is not something that certainly we can do without her there on the front lines with you, hearing your questions and concerns. So thank you to you, Cheryl, and others, many others who are on this call and part of the team responding, but wanted to just give a special call out and thank you to Cheryl as well. Trying to advance my slides here. So the first thing I want to mention is just changes to a couple of the call schedules. So we recognize the need for more information and more timely information and more timely engagement with all of you. So one of the things that we are going to do is to change up our school and childcare partner call schedule. Previously on a past call, we had indicated that we would have these calls once a month, and we're going to change that and have these twice a month on the first and third Wednesday of each month. Same time, 3:30 to 4:30 p.m. Still on Wednesdays, same call-in information, which is posted here, and this information will also be posted on our school and childcare resource section of the website, where we have been posting call-in information. So school and childcare partner calls first and third Wednesday of each month from 3:30 to 4:30. The other thing I want to update all of you on, give you advanced warning, is that we are going to be restarting our Thursday noontime healthcare provider and other public health partner calls. We will have those the second and fourth Thursday of each month, still from the 12 to 1 p.m. noontime hour. And the call-in information for this, the webinar information, is going to be updated to what you see here. And the information for these webinars will be posted on the healthcare provider section of our website. So we're upping the frequency of our school and childcare partner calls, and we are restarting our healthcare provider and public health partner calls the second and fourth Thursday of each month. And again, those Thursday noontime calls will continue to focus on relevant and important science updates and updates to the overall COVID-19 response. They're not going to be specific to any particular group of individuals, but we'll focus perhaps more on the science and the medical side of things. And so I think that's also relevant to many of you on this call. So be aware that we are changing up the call schedule here. All right. I'm going to begin with an epidemiology update. Typically, we don't start these school and childcare partner calls with an epi update, but we haven't provided one in a number of weeks, and so wanted to provide one here. This is a graph looking at the number of new COVID-19 infections each day in New Hampshire. The blue line is graphing the 7-day running average of the number of new infections per day being reported out. And you can see that, similar to actually pretty much the rest of the country, New Hampshire has been having an increasing incidence, an increasing rate of new infections each day since beginning mid-July. Currently, we're up to just over 400 new infections being reported each day in New Hampshire, and you can see that where we are now is actually comparable to where we were in the April time period, when we were experiencing a secondary bump in cases as we were coming down from our winter surge. Similarly, the test positivity it has shown a similar increase. There's a graph looking at the percentage of all tests, both antigen and PCR tests combined, that are positive for COVID-19. We're currently hovering around 6% of all tests that are positive. And actually, this has been hovering around the 6% mark for the last week or two, but still higher than we want to see it. And then the number of new hospitals, sorry, not the number of new hospitalizations. This is the hospital census shown here in the orange line. This is the number of people hospitalized each day in New Hampshire with COVID-19. In the last few days, we've been hovering around the 130 to 140 mark. So 130 to 140 people hospitalized each day in New Hampshire. And this has trended very similarly to the number of new cases and the test positivity data that I just showed you. And then finally, this is a graph looking at the average number of deaths per day in New Hampshire due to COVID-19 based on the date of death. Currently, we are seeing an increase in the average number of people dying from COVID-19, and this is also reflected in the numbers that we report out on a daily basis. And then finally, I just want to turn your attention to something we frequently talk about, which is the level of community transmission. What I am showing you here on this slide is how New Hampshire Public Health defines the level of community transmission at a county level. And there are two criteria: a test positivity criteria and a 14-day total rate criteria, that are used to determine when a geographic area, in this case at the county level, is in a minimal, moderate, or substantial level of community transmission. And community transmission is assigned based on the highest level identified by any one of the criteria. We've been getting a lot of questions about why we have different metrics from CDC's metric. So I just want to put out there that these are the definitions, the two criteria, the two definitions that have been in place since the beginning of September 2020. So if you remember back to the beginning of last school year, we developed these metrics and these criteria to be used in a variety of settings, one of which was around some guidance for when schools could consider transitioning between different instructional models. And we've since taken these exact same criteria and definitions and used them more broadly in other ways. And so these are the same definitions, the same criteria that we developed about a year ago. This was actually before CDC had defined more clearly their levels of community transmission. We continue to use and refer to these because that's what many of our schools and partners have been used to looking at and referring to. But I will say that these are very, very similar, not identical, but very similar to CDC's criteria. So for example, when CDC's map shows New Hampshire going from a moderate into a substantial level of community transmission, based on our metrics, we're not far behind, usually within a few days of, and this happened back in July and August, when within a few days of CDC's criteria showing the state going into a substantial level of community transmission, our metrics similarly showed us going into a substantial level of community transmission. So while there are differences, the different criteria are very similar, and the ultimate result of identifying a substantial level of community transmission occurs, very closely with changes that are seen in CDC's criteria. But these are the definitions, to put out here again, that we have been using and referring to for the last year, and this is how we continue to define the level of community transmission. And so it shouldn't be a surprise to anybody that when we look at the level of community transmission county by county, with the cities of Manchester and Nashua broken out, that the entire state is at a substantial level of community transmission based on these two criteria. Again, a 14-day total rate criteria and a 7-day test positivity criteria. And so statewide, we're at 387 total cases per 100,000 persons over the last 14 days. And our 7-day test positivity is what I mentioned earlier, 5.8%. We use these criteria to track the level of community transmission, and we use the level of community transmission to inform recommended mitigation measures. So we'll talk more about this in some of the coming slides. Because we're in the EPI section, I also just want to give an update on K through 12 school clusters. Over the last approximately 2 weeks to 2.5 weeks that school has been in session, there have been a total now, as of yesterday, 25 new K through 12 school clusters in the last approximately 2 weeks. All but 2 of these are active. And so the total number of infections associated with these clusters is 146 people that have been identified associated with these clusters in K through 12 schools. 92% of them are in children. The minority are in staff. When you look at the average number of cases per cluster, that ends up being about 6 infections per cluster, with a range between 3 to 16. Now, why am I highlighting this? Schools have only been in session for a little over 2 weeks, or a little over 2 weeks. This is a remarkable number of clusters to occur in schools over a 2-week period, and the majority of these are occurring in children. And so we're going to go through some additional slides, but you'll hear us talking over and over about the importance and the need for their continued need for there to be implementation of prevention strategies. And we're seeing cases and clusters rise in schools, I think highlighting again that point that there needs to be prevention strategies in place in schools to prevent infections, protect people's health, and to keep kids in school and in their optimal learning environment. So let's transition. Actually, before we transition, let me pause and see if maybe any other people from public health want to comment on the numbers, the epidemiology, or respond to any immediate questions that maybe have come in.
Yes, Dr. Chan, thank you. There's a lot of really valuable information there, and one that is following the data you just showed is a question regarding the difference between cluster and outbreak. So I think that there's been some concern that those names have been used interchangeably, that nomenclature has been used interchangeably, and we want to be intentional about that. So I'd invite a moment discussion from our experts who are in the real work of responding to clusters and outbreaks.
So sorry about that, Dr. Talbot. This is Lindsay Pierce.
Hi, Lindsay, thank you.
I do believe that we have a slide on this. Is that correct, Dr. Chan?
Yeah, we will touch on this because there have been a number of questions relative to the data dashboard and the school toolkit and how we define a cluster versus an outbreak. And so we'll very briefly allude to it. so perhaps that question could be saved for later, but we are going to clarify this and make sure that those definitions align both in the toolkit and on the data dashboard.
Good enough. Thank you very much.
All right, so let's move on here. I'm sure there's going to be a lot of questions. Going to go over old slides and incorporate some new information into some of the slides we've perhaps shown previously. So outlined here are the key prevention strategies highlighted by the CDC and by our guidance in the past. Vaccination, face mask use, physical distancing and cohorting, screening, testing, ventilation, hand washing, staying home when sick, isolation and quarantine, and cleaning and disinfection. So I'm going to go through each of these very briefly and highlight some clarifications and hopefully provide some potentially new succinct information or recommendations. So it's about prevention strategies, also known as mitigation measures. Mitigation measures are intended for population level control of COVID-19. And so we continue to recommend that they be implemented at a population level, whether we're talking about a state or a county population or a school population. But we have always based our recommendations on the level of community, which we believe reflects the level of community risk from COVID-19, so that there's a greater need for mitigation measures when the level of transmission is substantial, and relaxation can occur when the level of community transmission is minimal. And you've seen and you've seen this play out over the last months of this pandemic, so that when levels were low or minimal at the beginning of the summer, we recommended a pullback on mitigation measures. And as the numbers have taken off again towards the end of the summer and into the September, we have continued to recommend a greater need for prevention strategies and mitigation measures. And so I just want to put out there up front that with the level of community transmission currently at a substantial level statewide, as I have shown in just a few slides ago, we recommend that all schools and child care programs implement as many of the prevention strategies as possible to prevent in-school and child care transmission, not only, again, to protect the health of the individuals and the people in classrooms, but to keep kids in school and in daycare settings, to maintain education, to maintain the continuity of learning, which is important for kids. I'm going to first start by highlighting some points we've made on some previous talks around promoting COVID-19 vaccination. Vaccination, we continue to message as the most important tool we have to control COVID-19, to help protect individuals, protect communities, and vaccination rates still remain too low. We know that the COVID-19 vaccines are effective at preventing both symptomatic and asymptomatic infection. They remain effective against the Delta variant, and they certainly remain highly effective at preventing severe disease, such as hospitalizations and deaths. And we've gone over some of this data that's been coming out over the last couple of months on our Thursday noontime partner calls, and we will continue to highlight the efficacy of these vaccines and the safety of these vaccines into the future. Even if someone is infected with COVID-19 after vaccination, which is not common and is not the majority of cases, by the way, vaccination is still beneficial and leads to lower viral loads, shorter duration of viral shedding, lower risk of severe illness if somebody has a vaccine breakthrough infection, shorter duration of symptoms. So vaccines all around have huge benefit to the individual and huge benefit to communities. We continue to recommend that schools and childcare programs and businesses and all organizations help to promote vaccination and work with local healthcare partners and our regional public health networks to set up, in this case, school-based vaccination clinics so that vaccination can be more readily available at the point where people are in their communities. And again, we have linked here a contact list for our regional public health network representatives who can help have discussions with you on the ability of these groups to set up local vaccination clinics. I want to talk a little bit about face masks. Face masks, again, reiteration we've put out before, tended to protect both the wearer and serve as what we call source control, meaning to prevent someone who might have COVID-19 from spreading it to others. The CDC has estimated that COVID-19 transmission occurs from people who are asymptomatic, meaning they are without symptoms. And for this reason, face masks have become an integral part of the layered prevention strategies. Now, the recommendations on face masks have changed over time as we've learned more about this virus. So face masks are not generally recommended or necessary in most outdoor locations, but we recommend that face masks be used by people indoors in areas where there is substantial community transmission. So again, to put that another way, we recommend that everybody, staff and students, wear face masks indoors because of the high levels or substantial levels of community transmission statewide. Now, for schools and businesses and childcare programs that have an optional face mask policy, we would then suggest or recommend that you implement face masks when responding to clusters of infections or outbreaks in the school or classroom setting. But, you know, and this is sort of encapsulated in that decision matrix that we had put out in our school toolkit and talked about on our last school call. But I want to be very clear that the reason we recommend face masks indoors in areas with a substantial level of community transmission is to prevent COVID-19 from being transmitted in the school setting or the classroom setting. If you wait until you have a cluster or an outbreak, at that point, you're already behind the 8 ball, so to speak, and are dealing now with responding to existing COVID-19 transmission. So our recommendations that we have put out on past calls and in our toolkit, and that we want to reiterate here, is that because of the substantial level of community transmission, to prevent COVID-19 transmission in the classroom setting and in school settings, is that everybody wear face masks indoors as one of the layered mitigation strategies. Now, we've gotten a lot of sort of variations or questions on variations of this. Well, what about school buses, or what about school transportation to sporting events? Face masks must be worn on school buses. This is not simply a recommendation. This is a requirement based on CDC's federal order for face masks to be worn on public transportation, including school buses. So regardless of the ultimate mask policy at a school, passengers and bus drivers or transportation drivers are required to wear masks on school buses, including buses operated by public and private school systems. This is not our order. This is a federal order. We have vetted this with New Hampshire's AG's office, the Attorney General's office, and they have agreed that this is a requirement for schools under the federal mandate or the federal order. We've also been getting questions about situations where maybe face masks don't need to be worn. So here's a variation of that. Does New Hampshire Public Health recommend masks if students can be separated by at least 3 feet? What about 6 feet? So face masks are recommended if students are separated by less than 6 feet of physical distance. If students and staff are consistently separated by 6 feet or more, then I think schools and classrooms can attempt to go without face masks in those settings. But if it's acceptable to the community, then using face masks is still the more protective approach. So I think we would not recommend, so let me put this in the positive frame, we would recommend face masks anytime that students and staff are separated by less than 6 feet of physical distance. So let's talk about physical distancing. So all students are back to full in-person learning. The basic recommendation continues to be to maximize physical distance to the extent possible between everybody, with an ideal goal of being at least 3 feet of separation. Again, this is the same recommendation that was made this past school year, at the end of the school year. And we continue to recommend implementing cohorting in areas where it's feasible. This is not possible in many school settings, K through 12 school settings, particularly in older age groups and older grades. So this is really more important for childcare agencies where physical distancing between young mobile children may not be possible. And as community transmission increases, we continue to recommend more strict cohorting, smaller cohort sizes for childcare being considered. You know, we continue, there's not a one ideal size, but we've continued to put out there as one potential consideration of trying to get groups of children in childcare agencies, you know, to 20 or fewer children and staff in a group. And obviously the smaller the cohort, the more effective the mitigation measure will be. Screening testing. So screening testing is only recommended in K through 12 school settings, not childcare settings. Screening testing refers to testing people who are asymptomatic to detect infection early and prevent spread of COVID-19. There are multiple resources that are out there linked here, and there is funding and support to do this. It's still not too late to sign up with our, what we're calling the SAS program. Schools are not required to conduct routine asymptomatic screening testing when enrolled in the SAS program. Schools can use asymptomatic testing for reactive testing, meaning if there's evidence of a cluster or an outbreak, but only if you're enrolled with one of our state testing vendors. And so we continue to encourage schools to sign up testing, even if there's not routine screening that is occurring. Again, it can be an important resource in the event that testing a group of people is needed because of a cluster or outbreak. And here's a couple of new or clarified suggestions here. At a minimum, I think we would suggest that schools consider conducting routine asymptomatic screening testing on sports teams due to the increased risk posed by close contacts in larger groups. Now, why are we saying this now? You know, we're already starting to see some clusters in school sports teams. We are hearing about there being problems with clusters and transmission from other states related to sports. And then probably more importantly is our experience over the last year when we saw many and some very large outbreaks associated with sporting teams and sporting events. So if a school were to take a more targeted approach to implementing asymptomatic screening testing, we would suggest that a good place to start that is with sports teams as a way to maintain sports, maintain the activities, but try and identify infection early and prevent transmission among teams and actually between teams as well. We would also suggest that if schools are not going to strictly implement other mitigation measures, that they should consider implementing general staff and student population screening testing as a layered approach, as a layer of protection when at a substantial level of community transmission. And this is not a new recommendation. This was highlighted in the CDC guidance. We've mentioned this before, but want to put out there again that if a school has, you know, kids sitting, you know, less than 3 feet apart, no masks, you know, no cohorting, that likely will not be enough to prevent there from being some amount of transmission within the school setting. And this is where adding or trying to add additional layers of prevention like testing will potentially be beneficial for identifying infection early and preventing transmission. Ventilation, I'm not going to say much more about ventilation. There's you know, we continue to recommend that school and childcare agencies look to increase ventilation in their classrooms and in their buildings, and there's a variety of ways to do this. Whole guidance from the CDC on this. Take a look at the links, and there's no new information on this slide. We continue to recommend frequent hand washing and sanitizing of hands and teaching kids and staff, you know, good respiratory etiquette, how to cover coughs and sneezes, and then how to wash their hands afterwards. And then we continue to recommend that people, students and staff, children stay home when they have any new or unexplained symptoms of COVID-19 that might indicate an infection. We continue to recommend having a low bar for excluding and testing people. This includes people with mild cold symptoms, even singular symptoms, both for people who are and are not fully vaccinated. So even fully vaccinated people who develop symptoms of COVID-19 should be tested. And if you look at some of our past calls and past recommendations, we highlighted some New Hampshire specific data showing that, particularly in the younger age groups, like the 0 to 4-year-olds, that 10% or more of younger children may only present with a single symptom like runny nose or sinus congestion. So take a look at some of those past slides and some of the past recommendations where we highlight some of that data. But this is your first line of defense for preventing COVID-19 from being introduced by a person who is symptomatic into a school or childcare setting. We've also been getting a lot of questions about at-home test kits, which you can buy over the counter. Most of these at-home test kits are antigen tests, and at-home testing will be increasingly available and used within the community. You all may be aware, and probably are aware of the federal announcements where the federal government is making at-home test kits more readily available at cost to people. Pharmacies and other businesses have been selling out of these at-home test kits. And so we're going to see their use dramatically increase. And so we continue to recommend that school and childcare programs accept at-home test results for helping to clarify whether somebody with symptoms may or may not have COVID-19. When the instructions are followed closely and when swabs are appropriately collected, the at-home antigen tests should have comparable accuracy to provider collected swabs and antigen testing. And there's actually some studies that have come out more recently comparing at-home testing to, for example, PCR testing, and at least to my recollection, have shown comparable accuracy to provider collected antigen testing. For people that may not have access to at-home test kits, can't find them, or don't have the money to pay out of pocket, there is a list that we still maintain on our website linked here for testing locations around the state that people can access. There are hundreds of testing locations, both at provider offices, hospitals, urgent cares, and commercial pharmacies. So take a look at the resources linked here for where people can seek out testing if they don't have access to at-home test kits. When a symptomatic person return to school or childcare. So this is not a new recommendation, but we want to highlight this again because we've been getting questions again about when somebody with symptoms can return. If a person tests positive, or if they choose not to be tested, they can return when they've met the criteria for discontinuation of isolation. So that's going to be at least 10 days of isolation. If a person tests negative, we still say that they should not be allowed back into school or childcare if they're sick. So they should test if they test negative, they should be afebrile, meaning without fever for at least 24 hours, off fever reducing medications, with other symptoms improving before returning. So again, a sick person should not attend school or childcare. Now, there will be situations where perhaps somebody has very, very mild symptoms, maybe singular symptoms. They test negative, and the question is going to be, well, they have a little bit of a runny nose, they tested negative. Can they be allowed back in the classroom? And I would say in those situations where a kid is not particularly sick or a staff member is not particularly sick and they test negative, you should feel free to use your judgment. But in general, if somebody is having cold symptoms of viral infection, maybe they're having a fever, they should not return until they are improving and afebrile for at least 24 hours. A lot of questions coming in about contact tracing and about isolation and quarantine. So this is an important slide, I think, for people to take note of. New Hampshire Public Health is focusing on investigating clusters and outbreaks and not conducting routine contact tracing for individual cases and community exposures. So because this prevention layer is being relaxed, and remember that contact tracing, isolation, and quarantine is one tool, one layer of protection that we have. at preventing spread of COVID-19. But because this prevention layer is being relaxed statewide, it's important to implement other layers of protection more strictly. And that's part of the reason that we have recommended, for example, face mask use in indoor settings, particularly because school and child care agencies are dealing with a largely unvaccinated population. Now, people who are diagnosed with COVID-19 must still isolate at home until they have met the criteria for discontinuation of isolation. And again, that's at least 10 days of isolation. We continue to require that unvaccinated close household contacts of someone with COVID-19 also quarantine. So this includes people living or sleeping in the same household as somebody diagnosed with COVID-19, again, unvaccinated close household contacts. And then the large group of non-household or community contacts and vaccinated household contacts are recommended to self-observe or monitor for symptoms, wear a mask for 14 days after a potential exposure, and get tested around day 5 after an exposure, even if asymptomatic. Now, all of these instructions are outlined in our self-observation guide, which we have put out there as a resource for schools and community partners. So, well, public health contact tracing is not being conducted routinely for individual cases. School and childcare programs should still make an attempt to identify who may have been exposed to a person with COVID-19 in a classroom setting and provide them with the self-observation guide instructions that are linked here, and hopefully you all are familiar with. We've also been getting questions, if public health is not investigating each and every case of COVID-19 that occurs in the community, should school and child care agencies still report individual cases to New Hampshire Public Health? And the answer to that is yes. We still ask that schools and businesses and organizations report cases. Your report may be the only way we know a case, an infection, is associated with your facility. This gets to issues with timeliness of the school dashboard data. If schools are conducting testing on people, then under New Hampshire law, any person with suspect or confirmed, in this case, COVID-19, be reported by not only laboratories, but also healthcare providers. And so if a school is conducting testing, the school, for example, point of care antigen testing, then the school is considered the reporting provider in this case. There's a couple of ways to report. You can certainly call our main public health hotline, 271-4496. There may be a delay in getting through to us because of the volume of calls. One of the other ways to report a case is to complete the COVID-19 case report form and fax it to the number listed here. The information that we typically request is listed on the right-hand side. It involves some PH health information, which we keep confidential, but is important so that we can reach out to the individuals if needed, and so that we can help know whether there may have been an exposure in a school or classroom setting. So take note of the information that typically we request, take note of the numbers, the contact information here, but we still do ask that cases that have been in school or childcare settings be reported to New Hampshire Public Health, if for no other reason than because it's one of the ways by which we know to assign an infection to a specific school or facility, and also helps identify if and when clusters or outbreaks might occur. And then this brings us to the question, why aren't the numbers on the school data dashboard accurate? So we are actively working on making the school data. Oftentimes, as I mentioned, schools, and it may take a few days before those cases are reported to public health and appear on the dashboard. But I want to stress again that we need the individual case reports from schools in order to associate a person with COVID-19 with that particular school. We've also been getting questions about our definitions of clusters and outbreaks. The definition of cluster and the definition of an outbreak have become discordant between the data dashboard and our school toolkit. So we are updating the definitions in the toolkit actively to try and align with the current data dashboard definition. So this has caused significant confusion, but it's actively being addressed. So just to say this another way, the updated school toolkit that we released over the summer had updated the definitions of what constitutes a cluster and what constitutes an outbreak based on some updated definitions that the CDC had put out. But that made the toolkit out of alignment with how we had been defining a cluster and an outbreak in the past, and how it's reported on the data dashboard. And so for consistency and to try and prevent there being confusion, we are going to revert to the older definitions that we had been using all of last year for what constitutes a cluster. So 3 or more cases, linked, epidemiologically linked in for example, in a classroom, and an outbreak being that of multiple clusters occurring in a school or facility setting. So if you want the exact wording, I don't have that on these slides, but if you want the exact wording, what you can do is you can go onto the school data dashboard and hover over the number of clusters and the number of outbreak column headers, and there will be a pop-up which shows you the definition, the exact wording of the definition for what a cluster will be defined as and what an outbreak will be defined as, and it's the same definition that we were using last year. Let me actually pause there and see if anybody wants to add to this, because it sounded like there were some questions around this.
There were a lot of questions, Dr. Chan, but I think that slide answered a number of them. Okay, great. And then just a couple more slides here. Cleaning and disinfection, yes, no information here has changed. Take a look at these links again, highlighting again the key prevention strategies. Given the substantial levels of transmission, we continue to advocate for and recommend as many provisions as you can implement in the school setting. And then a couple last questions. When will we stop needing to implement all these prevention strategies? And to reiterate what we said, I think in June or July, once vaccination is available for school-aged children, and once children have had the opportunity to be vaccinated, we will more actively work to transition away from relying on mitigation measures, right? At that point, vaccination becomes available. People have had the chance and the opportunity to be vaccinated. So the mitigation measures like face mask use are really intended to be a temporizing bridge until we can vaccinate younger age groups. You've also seen that we've tried to relax the recommended prevention strategies when community transmission is lower, like it was at the beginning of the summer. But ultimately, this will happen more quickly when people get vaccinated. And so we keep coming back to the importance of vaccination. But when vaccination becomes available to younger age groups in the near future, we will more actively try and transition away from relying on some of these mitigation measures. That brings up the question of when will vaccination be available to younger children? So we had expected emergency use authorization, or EUA, or approval of the COVID-19 vaccines in younger children this fall. We've been saying that for months. More recently, we've heard from federal partners that it may be by the end of this calendar year. And if you're looking and paying attention to some of the media, we're now also hearing reports that Pfizer-BioNTech may have data to submit to the FDA by the end of September vaccine, particularly for children ages 5 to 11 years. So once data is submitted to the FDA for consideration for emergency use authorization, or EUA, then it takes the FDA some amount of time. And so best guess, possibly sometime earliest by end of October, maybe towards the end of the year. But the exact time frame of when vaccination will open up to younger age groups still is a little bit up in the air, but likely vaccination will open up first in this age group, the 5 to 11-year-olds, which should cover really the K through 12, all of the K through 12 setting, approximately. And then finally, before we move on to questions and answers, any other comments from anybody else on the team here?
I would add that it appears to me that you've covered just so many of the questions that have come in with these coherent slides, which will be posted and available to you for review. And this presentation also is being recorded, so you can come back to it. I have seen multiple questions around understanding the testing platforms better, which is better under what circumstances. And I think that whichever is available to you, it's simply important to understand the strengths and limitations. So we've talked many times together on this call and also in the long-term care facility call and in the partner call that the antigen tests are just an incredible asset to us for a fast result. That's likely their strength, and they also can be administered at home, but they may have some reduced sensitivity for those who are asymptomatic. So we've just encouraged you to look at some of the algorithms that are out there, and this SAS protocol, this program, also embeds a lot of information that I think will help you to begin or continue to distinguish between the different platforms that are out there. I echo what Dr. Chan said, that the home-based tests are likely to take on a more important role as the months and years go on. So understanding each of those can be useful, as well as your community brings those results to your attention. So I just wanted to circle back to the multiple questions that exist around testing within our Q&A.
Great, thank you. So we have maybe 10, 15 minutes left on the call, and I'm sorry, we haven't probably left as much time for Q&A as I should have. We will reconvene in the first, go to the slides here, the first and third Wednesday of each month. So we're upping the frequency of these calls, but I'm wondering if somebody, I don't have the ability to, screen through 144 questions. I wonder if somebody can potentially summarize and throw out in more general terms some of the questions that have been asked for us to answer.
Sure, Dr. Chan, I'd be happy to start with that. You have a number of questions regarding childcare exposures, and particularly if children in the childcare setting are considered household contacts or community contacts. So I'm happy to address that. Currently, our definition of a household contact applies to individuals who live or sleep in the same indoor shared space as another person diagnosed with COVID-19. And we do consider this in temporary or permanent situations. However, at the moment, we consider childcare to be community transmissions, as well as schools, in which case, if there were a case of COVID-19 in a school classroom or a childcare classroom, we would advise that individuals self-observe. So they're not required to quarantine, but we would prefer that they self-observe, and I can leave a link to the self-observation guide in the chat for folks. I think we've heard that that's an easier place to copy links. And self-observation will walk you through the fact that individuals should monitor for symptoms, get tested, and wear a face mask in indoor public places, and seek testing and isolation if they become sick. And hopefully that addresses. Dr. Chan, did you want to add anything to that?
Yeah, the only other thing that we've also said in the past is that public health always sort of reserves the right to expand quarantine in the setting of an outbreak setting. So if there's like a large outbreak in a classroom, for example, or in a childcare agency, we have public health has the option of using that as an outbreak control measure. But before we even did that, we would look at other prevention strategies that could be implemented to prevent the need for like an entire classroom being out on quarantine, for example. And that would include face mask use, testing, trying to implement testing for a potentially exposed group of individuals. So there's other options, other layers of prevention that we have before we would get to the step of potentially quarantining an entire classroom. That's what we were doing last year, and I think we found that there was not a lot of in-classroom transmission, either in schools or in childcare settings. But again, that was in the setting of implementation of multiple layers of mitigation, including face mask use. And so that's part of the reason that in the setting where we're pulling back on some of the on quarantining of entire classrooms, that other layers of prevention be employed.
Dr. Chan, I just want to add some additional clarification around the topic of quarantine, since there's a number of questions in the chat around this. CDC recommends quarantine still for anyone who has been exposed. So someone in the questions mentioned that when kids or families are going to their healthcare provider is recommending quarantine for them because they've had an exposure. When from the state health department vantage point, we are looking at our legal authorities and plans around isolation and quarantine, and we are no longer quarantining people who have had outside of their home or non-overnight community exposures. So that's the distinction there. And I understand it's complex and it results in different recommendations being given to people between us and the providers. That is a fair recommendation to make for them to quarantine. CDC recommends it. We're not quarantining people not because there is not risk there. There is risk. The risk is lower for people who don't live together. And understanding that we are moving forward in a time where COVID is going to be with us for a long time to come. And we're moving towards treating it like other respiratory illnesses. So we're no longer doing that community contact tracing and requiring quarantine. We want to keep kids in school, and we have not seen evidence of significant transmission in these community settings historically. So that just to provide a little bit of more context around that.
I'll pick up on it.
Go ahead. Oh, I was just going to quickly say that, scrolling through some of the questions, related to this and related to the question of contact tracing. I'm also, and I tried to take this on in the slides. There's a question, if we're not going to quarantine kids and students, why are schools being asked to do, why should schools contact trace? And I think this is sort of a little bit of a nuanced message, right? We're not necessarily asking schools to conduct the type of contact tracing that has been typically conducted in the past to identify, any and all students that may have been within, 6 feet of someone with COVID-19 for 15 minutes or longer within a 24-hour period. That's a very sort of strict definition of an exposure. But really, we're asking schools to identify potential exposures. A classroom where somebody with COVID-19 was present, to share with them that self-observation guide and those self-observation instructions, so that people who are potentially exposed are provided the information to wear a face mask and get tested around day 5 and to monitor for symptoms and to have a low bar, a low threshold for going to get tested if any symptoms should develop.
There are several questions that are asking also for an update with regards to the epidemiology of the variants. There are those of you who clearly understand that Delta has become the predominant variant in country and in state. And the very good news is that the vaccines do prevent hospitalization and death from that variant, but indeed that there may be a appreciable increase in breakthrough disease for those fully vaccinated. We are taking, of course, a very important topic within our partner calls to stay aware and communicate what we hear about the possibility of boosters, but this remains to be clarified by our federal partners. So just to give that brief epidemiologic update regarding Delta.
I can see that there's still questions around quarantine coming in, so I don't want to leave people hanging with this and around the contact tracing process. We are not requiring quarantine or asking you to do detailed contact tracing when you're identifying cases in your school setting. What we want you to do is to notify people who may be in that classroom or the school, depending on what your own protocol is and how you've decided you're going to communicate with your community, that a case has occurred in the setting, and that providing them with that observation guide. So you're not required to quarantine students anymore based on their exposures within the classroom. The only people that we are requiring quarantine for are unvaccinated household contacts, meaning people who have had overnight stays together. There's also quite a few questions around rapid testing and accepting those home test kit results. I don't know if Dr. Chan or Dr. Taub, if you had a chance to see some of the types of questions around that, and maybe you can repeat some of our prior messaging around accepting home tests.
Yeah,
So,
go ahead.
I do think that Dr. Chan has a slide dedicated to that. So circle back and review that at your convenience. But indeed, we do see it as the future. That is, people will recognize that it's more convenient to take this test at home, and that performance is likely adequate, particularly in responding to a positive test. So in this bullet, at-home tests will be increasingly available and used. We recommend that you accept these test results in part because they are accurate and also they are especially accurate in those who are symptomatic. So a negative antigen test in a person who has appropriately used according to manufacturer instructions is likely to be highly predictive of true disease state. So please do become acquainted with those that are being used in your own community and accept those results.
And I think there's some misinformation in here that people are hearing that you can't use the antigen tests on vaccinated persons, and that's not correct. If someone is vaccinated and they're symptomatic, you can still go ahead and use that antigen test.
Absolutely. Thank you, Dr. Daly. What we know is that persons who are vaccinated who experience symptoms and what is indeed breakthrough disease are as likely to have positive testing as those who are unvaccinated. So I think the simplest way to proceed is to ignore vaccination status when you are evaluating someone who is symptomatic and is suspected of having COVID-19 based on the symptom screen.
Yeah, and either antigen or PCR testing is acceptable for somebody who's symptomatic, regardless of their vaccination status. Are there one or two other high priority topics maybe we can pick off in the last minute or two?
There's a question regarding why is isolation only 10 days when people are generally sick or longer than that? And you're exactly right. I very much appreciate that you've brought us around to how prolonged this illness can be for some people, and even the reality of PACS, post-acute COVID syndrome, that exists for adults and children who become infected. However, the 10-day time-based release from isolation reflects their infectious period. I just wanted to circle back that even though there may be residual symptoms for weeks or months even, they are unlikely to transmit to others, and the science has dictated and we have endorsed the duration of isolation, as you've been hearing, for more than a year now.
So I do think we have to close the call now. I did want to let you all know that we do have over 180 questions that you all have written into us. And so certainly we know we may not have gotten to many of the topics that are very specific questions that you have. What we'll be doing on these calls going forward is to skim through all the questions and address the themes that we're able to, where many people are asking questions. If you have a very specific question or consultation, we are here to support you by calling us at 271-4496. And we have Cheryl Nielsen, our educational liaison, and then we'll be going through all of the questions we didn't get to and try to address some of those topics the next time we meet on the first Wednesday of October at 3:30.
And so the next meeting we will have will be the first Wednesday of October, October 6th. We'll have another call after that, the third Wednesday, and we'll keep up this schedule into the foreseeable future. Also want to reiterate for those that may have joined late that we are also restarting our healthcare provider and other public health partner calls that we were having on Thursdays at noontime. We will have these calls the second and fourth Thursday of each month. And on these calls, we will share more science updates and questions and information, share information and answer questions that are really pertinent to most people, and address many of the questions we continue to get around vaccines and what's happening with vaccination. So please tune in to these 2 calls going forward. I'm sorry we didn't get to many of the questions. We'll do our best to try and shorten the informational or didactic section section up front and try and leave more time for questions in the future. But thank you all for your interest in partnering with us going forward. Appreciate your time.
And the slides will be available on our website probably tomorrow. If you want to check them out there, we put the link in the chat. Thank you all.